these cases here are so hard with braces. They're almost impossible to treat without utilizing a TAD because all of these teeth, as soon as the braces go in, are going to try to extrude. Now, the beautiful thing about using aligners is full coverage of plastic here, is that when you're intruding any tooth in the mouth ever, you need to have an attachment on the neighboring teeth, always and forever. There's no ifs, ands, or buts about it. If it's pure intrusion directly into bone, you must have an attachment next to it. So what are we going to do in this round? Well, we're essentially just doing some expansion in the upper right, a little bit of constriction in the lower right, and working on arch coordination. So this is a female patient coming into our office, and the chief complaint for her is, well, there's not a significant one to begin with. The chief complaint is essentially that she was in for her general dentistry, and we talked to her about the chipping, damage, and wear that's happening to her teeth. Now, here's the thing is that I see so many cases coming from doctors, and what they're sending to us is essentially a bilateral posterior crossbite with an anterior crossbite and saying, this is a patient who came to our office and they really, really want treatment. They won't go to an ortho and they won't do surgery. How do I treat this posterior bilateral crossbite with an anterior crossbite? And the answer to them is surgery. This is a surgical problem. Well, they don't want surgery. Well, to be honest, we can't help that. This is deformity of the skeletal. And so if we are trying to compromise by extracting lots of teeth or doing other options, we're just compromising. And this is the hardest case that's the most challenging to treat and the most likely for you to get stuck halfway through and to end up in a lawsuit. And so cases that are so much better for us to be taking on are these cases where we talk to patients about issues they might not know that they even have at this point. Because it's not that we shouldn't talk to that patient about their problems and explain that they would benefit from orthodontic treatment. It's just whether these are the appropriate cases that you are best suited to take on at this point. So in this situation, what we're talking to the patient about is the chipping and wear. I mean, when you look at the incisal edges, you can see translucency through the tooth because she started to wear the lingual surface of her teeth. We see chipping on her lower incisors. And usually what's going to happen, it's the tooth that's most buccal that's taking the most damage. So when you look at the lower left lateral, this tooth right here is not taking a significant amount of damage because the lower central incisor, the lower left central, is what's taking the damage and wear. You can even see how the light is reflecting off of it. Now, I'm just showing you on the photos. Ideally, you're showing them on the iTero and the outcome simulator because that will show so much better. But the patient, even with just showing the photos, sees and recognizes the wear and damage that's happening to the teeth. Same thing with the canines, how worn down those teeth are. And so that's the discussion for our patient is we're not doing this for aesthetic purposes. We're doing this because she's damaging her teeth. And we want to go ahead and create a better bite for her so she doesn't continue to do that. You see the same thing when you look at her ClinCheck. You notice how the corner of the tooth is worn down. You also notice the size between the left and the right centrals. Right? It's the same thing in her photos too. When you look closely, you can see that the left central incisor is taller than the right central incisor because the right central incisor has worn down more and then it's slightly super erupted. And then it continues on that pattern. And so those are the initial discussions with this patient. The other discussion, of course, is going to be the extraction site and how our lower first molar has tipped forward and the upper first molar or the lower second molar tipped forward and the upper first molar has extruded into that space. And so from a conversation with her, she would like to set this up for being able to put an implant back in there and restoring her function. Now, other than that, there's nothing too remarkable. She's biting in a class 1 on her left side. On her right, she's a slight class 2. And so the option we present to her is doing orthodontics and essentially doing Invisalign. So let's go back to our initial setup and we'll take a look to review what are the key components to her case. Okay, so this is the first ClinCheck that we're receiving back for this plan. Now, what you'll sometimes see me doing when we go through these case reviews is that I'll go through a checklist item by item to show exactly everything going on with this case. I'm going to do a little bit differently this time. I'm not going to go through everything on our entire checklist about every decision to make. I'm going to key in more on the specific decisions and where you would make those adjustments. Okay, so to start with here, we know that we need to work on derotating our incisors, which is pretty straightforward. To derotate lower incisors, you don't need anything special for attachments. Those teeth are going to derotate very, very easily. But let's talk about our lower canines. Our lower canines, they need to have some rotation. And what's currently planned on those canines is an optimized rotation attachment. Now, the thing with the optimized rotation attachment is that it often works really well. Many times when we have this optimized rotation attachment, even though it's really small, because it's mostly just rotating the tooth, there's no significant root tip, right? Buccal or mesial distal root movement happening. It's really straightforward for that tooth to rotate with the optimized attachment. But here's the thing is if we leave this attachment on and the movement doesn't fully happen, what we're going to end up with is a situation where we need to remove and replace this attachment with another optimized rotation attachment. Because the attachment is so small, the recommendation will always be from Align, when you have an optimized attachment, especially a small one, remove it at the end of every set of aligners. Whereas the conventional attachments that are on the teeth right now, we can leave those attachments in place. We don't have to take those attachments off because they're larger. And so when you scan those attachments, you're going to have the ability to just to leave them in place because the way that the aligners work is slightly different between the optimized Invisalign placed attachments and the conventional attachments. So that's the first thing that I would look at on this ClinCheck and say, that's something that I want to adjust. Now, I'm going to jump ahead. This is our final results. I'm cheating because you guys are going to see everything worked and it worked really well. But I just want to modify this plan so you can see how we actually can make that change, right? Because you can take control. And this is one of the most important things with ClinChecks is being able to use the 3D controls to place your own attachments and orient them so that you don't rely on the technician to do this for you. Because this is such an easy, straightforward thing to do, which then saves you all that work of trying to type and talk to the technician. So you can grab your attachment, drop it down on the tooth. I like 4 millimeters when I have the rotational movement for these canines. Now, again, we're in a finished position here where we don't really need to do anything, but this is just showing how you can position the attachments on the teeth. Same thing with any of the premolars. If you wanted to change the height, instead of being close to the gingiva, and move it up to the incisal or occlusal edge, you have the ability to do that. In terms of placement, I always recommend placing attachments closer to the occlusal aspect because, and nowadays they actually don't even let you go lower. Back in the day, you'd be able to place the attachment right here if you wanted to. And lots of doctors did. But the problem when the attachment is so close to the gingiva is the plastic is so flimsy next to the gums. So it's really not ideal to have the aligner try to grip right where it's at its weakest. Whereas the closer to the occlusion that it is, then the stronger you're going to have the plastic in that area and the better it can snap in and make the movement actually occur, or that it will lock in and allow the tray to do whatever it's doing in the other areas of the mouth. Because it's not always just about the tray pushing against the attachment. Sometimes these attachments are being used to help with a deep bite or a support for another movement. Now, I'll get questions all the time of, well, what do you do though, Stephen, if the patient bites down on these attachments? Well, the first thing I would say is, honestly, who cares? Now, that's maybe not the answer you're expecting, but the reality is I don't really care that much if a patient's biting down on attachments. When they're in their transitional bite, everything is going to feel weird, everything. And so I'm not that worried because I have had so many patients before where I have left them occluding on their attachments. As long as you have good bonding protocols, they're not going to bust off the attachments frequently. I will give you the solution for how you can make sure they're not biting on their attachments in just 1 second. But in most cases, I really don't care that much if they're biting on their attachment because the transitional bite feels weird everywhere. But here's the situation for how you could go ahead and make a change. So right now, when you look at the bite, the area that the attachment is functioning when it's on a lower premolar or molar is the area where we're functioning with the attachment is the gingival aspect. So right in here. And so if you were to take a burr, and let's just do a little screenshot here. Okay, let's do green. Okay, you take your burr and you were just to trim down everything up here and remove this because the gingival aspect again is the area that is actually active. Or not active, I should say, but the area that's being used. If you go ahead and do this, where you just remove the extra portion of the attachment that you don't need, then you've just created an optimized attachment. That's exactly what this is, right? All the optimized attachments are these half moon attachments. Now, of course, you could go ahead and just use an optimized attachment, and that would do the trick for you too. But why I like the conventional attachments is that they do have more surface area than the optimized attachments. They can be pulled thicker, and they can also be made wider. So there's more surface area for the tray to lock on the gingival aspect. Because again, the area that we're focused on right now, where the tray is most active, is this area right here. Again, I shouldn't really use the term active, but it's the area where the tray is being engaged on these lower premolars. Always. It is always this aspect that's being engaged. Okay? Now, in our initial situation here, again, with the optimized rotation attachment, it's not that the movement won't fully express. It's just that that movement is, it might not my goal is to make you consistent. So when you click accept, it's going to work 90% of the time. And if it doesn't work, we've already planned for what we're going to do when that doesn't happen. And so by having the conventional attachment in place, you just scan, you get a new batch of aligners, you don't change out any attachments, and you keep going. That's the beauty of it. You're not wasting your chair time. So that's the considerations with the canine. We do have to intrude our incisor slightly. And so that's where we have the attachments on these premolars and the first molar. I guess I'm kind of jumping ahead, just how I moved them up. I guess I'm pretty consistent with what I just said. So we move the attachments up where the plastic is better for its retention. And what's happening now is that the trays, what they're doing here is they're pushing down. So the tray is actually pushing down right on the incisal surface of these front teeth. This is where it's pushing down. Whenever you see a movement on a ClinCheck, think about how the bottom bar is essentially showing how each individual liner is going to be making a movement happen. And so we see it getting intruded on the ClinCheck. So that means that the tray, each one of them is going to be pushing down on that incisal surface a little bit more and a little bit more. And so the goal here is to say, okay, how do we ensure that the tray stays on? Because often what will happen is in the back, the tray is going to pop off the teeth. So let's take a look. Oh, we can go this screen. Okay, so say that this is tray number 1, where the tray fits perfectly over top of the teeth. Well, then by the time that we start getting here to tray number 40, well, the size and shape of the tray has changed now. The size and the shape at this point is like this. And so it's trying to push down in this region right here, because that's where the teeth are moving. But what often will happen is that the tray, instead of pushing down against those incisor teeth, if there's no attachments at all in this region, what's actually just going to happen is the tray is going to pop off of the back teeth. So it'll fit on all the front teeth, but it will pop off in the back because there's no attachments to help lock it in. You can think of it like a teeter-totter. We need to have the teeter-totter. I guess I do need to go to this screen. We need to have the teeter-totter here essentially locking in, so as we push down on the anterior incisors, it doesn't pop up on the posterior. So that's the reason that we need good horizontal attachments, whether they're conventional attachments or whether they're optimized attachments. Because you could also go ahead and use this button right here to place an optimized attachment, and you would be going with an optimized retention attachment. Same thing on the premolars. You could drop an optimized retention attachment if you wanted as well. But the recommendation from Align, because they're slightly smaller than these conventional attachments, would be to replace it at every refinement if things aren't tracking. Okay, so that is the philosophy of why we have the attachment on the lower canine for rotation and on the premolars and molar for the deep bite correction. Let's go ahead and take a look at our other side. This is where things are more complicated. And interestingly, the case that you guys chose as case number 2 actually shows a very similar situation where we have a tooth that's tipped and we're going to be trying to upright the tooth. So here's the situation. This patient is currently occluding against their lower second or third molar and their lower second molar because the lower molars have drifted forward. Now here is the decision. We could go ahead and treat this really, really, really easily. All we have to do in a case like this, if we want to, is simply just distalize or extract the third molar on the lower, distalize this second molar, and as that tooth distalizes and uprights, you'll create 10 millimeters of space. And as you create 10 millimeters of space for that first molar, you place an implant, essentially extract the third molar, and you place a molar-sized implant. But the thing is that this patient is not completely convinced that she's going to do treatment. And when we discuss the options here of removing the third molar, she's not on board with it, in part because she is functioning with it and has occlusion. She's able to keep it clean right now. But the challenge is going to be is that she's not going to be able to do that if, well, she might not be able to do that if we distalize this to make the space a lot bigger. Because as we back up the third molar, it could actually impact it in soft tissue on the distal side, and then we're in that situation where we need to remove it. So what was discussed was she really, really doesn't want to take out that wisdom tooth. And so the alternative option then is to say, why don't we create an implant space here, which is the appropriate size for another premolar. So instead of finishing this case in a perfect class 1, we'll go ahead and leave it. Well, we'll leave the canines in slight class 2. We'll leave the molars here closer to class 1. We'll place a premolar sized implant. So that was the discussion with the patient. So let's go ahead and break down these movements so we can talk about what our options are. Because this tooth is super erupted. Now here's the thing. This is such a beautiful, amazing thing for you guys. If you only get one thing out of this lecture, this alone will save you, I shouldn't say save, will make you, like this one point that I'm going to tell you right now is going to make you, let's see, you're going to see 2 of these cases per year in your practice. You're going to intrude the teeth, and if you place the implant yourself, so let's say you charge $6,500 for the Invisalign case and your lab is $1,500. So you're going to make $5,000 on this case. You're going to place the implant too. I don't know what your implant price is. Let's say $5,000. So $10,000 for the whole case. You're also going to do 2 of these. So that's going to be $20,000 billed per year because you can handle these cases really, really easily. So if you have 10 years left of practice, well, this is now $200,000 worth of billings that you're going to be able to do as soon as you leave this webinar, because this case for this particular movement is so easy and straightforward and consistent that I never want you as a doctor to see this again and think, I can't do this movement of intruding this tooth. It is so easy. And again, on the lower, it's so easy as well if you extract the tooth, but I'll show you here how you go ahead and plan these movements from both of these 2 cases. So there's no reason that you ever shouldn't be able to do whatever you need to do in this region to set this up for an implant. So what do we need to do? Well, I want you to think, we need to intrude this first molar. So if we're going to be intruding that first molar, if you were pushing on this tooth right now with your fingers and you had to push somewhere on it to make a movement happen, where would you push, right? Forget about, I know you're thinking, what are you talking about? These are teeth in someone's mouth. Ignore all of that. Just think right now, the teeth are sitting in wax. You need to intrude your first molar. Where do you push? It's simple. You're just going to go ahead and you would push with your finger up on the occlusal aspect of the tooth, right? Nothing crazy about this. You'd push up with your finger right there, and it would intrude this tooth. Oh, undo. Okay, so hopefully everybody's still with me on this very, very challenging concept of push up on the incisal edge. Now, what's so hard with this case, if you were doing this with braces, is that with braces, this is an absolute disaster because you have your brackets on all the teeth, okay? And then you're gonna have your arch wire now, and your arch wire is going to run on the buccal surface between all the brackets. Really, I should. But what brackets do an absolute terrible job of is controlling the vertical. As soon as you put forces on teeth with braces, they will always try to extrude. They're always going to try and extrude. Because when you put a force on a tooth with braces, I always love asking this question when I'm lecturing. You have braces on the teeth and you have a force that's occurring on them. Which direction is the easiest direction for a tooth to move? Is it intrusion going pure into bone? No, it's not going to be directly into bone. Is it going to be mesial root or distal root tip into bone or torque into bone? No. Rotation, that's pretty easy. The other thing that's quite easy, extrusion. You put a force on a tooth, a little bit of space opens up between the periodontal ligament and the apex of the root, and extrusion occurs. And osteoblasts build back in the bone. You don't need any osteoclastic activity. And so I know we're taking a tangent right now, but these cases here are so hard with braces. They're almost impossible to treat without utilizing a TAD because all of these teeth, as soon as the braces go in, are going to try to extrude. Now, the beautiful thing about using aligners is full coverage of plastic. So from the very beginning here, the plastic grips over top of the occlusal surface, 360-degree coverage. It allows you to push up on this tooth and create that intrusion movement. Now, how do we go ahead and ensure that that actually happens? Well, the ClinCheck right now is showing this tooth pushing up. But if you had 0 attachments on these teeth, what would actually end up happening is tray number 1, sure, it's going to look really good. It's going to look like this. It's going to fit perfectly. Tray number 2, well, it's trying to push this tooth up, right? If we go ahead and look, the other teeth are all staying in the same vertical plane. It's just this tooth that's getting pushed up. So as the tray starts to look like this and changes its shape, we think, okay, great, this is now going to cause intrusion in this area, right? There's a difference between, I'll draw it with the blue here, between how these trays are fitting. This is changing and it's getting pushed up. But in reality, what ends up happening is the tray just comes off the teeth. It sits higher up, it comes off the tooth, or sorry, it will sit tight. Get this right. I'll just even do this, go back to tray 1. What's going to happen is it's just going to pop off these back teeth. It'll fit snug on the 6. And then your patient will say, yeah, my tray's kind of popping off my teeth. It's not fitting properly. Well, it's because there's nothing locking the tray in these regions. So the solution to this problem is attachments. If there's attachments that are locked on next to the tooth, that is the most significant movement, well, then that is going to allow the tray to lock in. I'll do that here with yellow. And so the tray will snap in, it'll still push nice and tight and be engaged on the occlusal surface, and it will lock in this area right here on the gingival aspect of that tray where it snaps in place so it can put the force up on the occlusal surface. I hope that makes sense right now for you guys. If it doesn't, don't worry too much about it. Just make sure that you're in Vegas in 2 weeks. No, I'm kidding. No, if it doesn't, the key takeaway is just to recognize the fact that the main point here is that when you're intruding any tooth in the mouth ever, you need to have an attachment on the neighboring teeth, always and forever. There's no ifs, ands, or buts about it. If it's pure intrusion directly into bone, you must have an attachment next to it. And so our original plan then, showing this tooth with an attachment, and then these guys have attachments, but there's no attachment on the 7, it is set up to fail. It will not work effectively because we need an attachment on that second molar to lock the trays in place. It'd be the same thing if we're intruding anterior teeth. We're going to want to have attachments next to the teeth in the anterior that will intrude. So what are we going to do? We're going to change this orientation. And in reality, what we could have done here is we don't really actually need an attachment at all on the tooth that is intruding. So this tooth that's intruding right here, it would have been completely fine without an attachment on it. It does not need that attachment because the tray's pushing up from the occlusal surface. And you guys are going to see, I'll jump ahead and show you now on our next ClinCheck what things actually look like with the intrusion. This is after our first round of aligners. All right, from here to here, let's just pull up the comparison. If you guys aren't using the comparison option, you really, really should. I use it on every single refinement to see what I was supposed to be doing and what I actually accomplished. But if you look, this will intrude every single day of the week. There's absolutely no doubt that it will work. Okay, let's go ahead and take a look now at our lower first molar. And I'm going to show you things here that I don't do as well as I should. So one of my goals when I'm lecturing to you virtually or in person is I really want for you to see my mistakes and things I can do better, because that's how I learned. So I'm not trying to show you Instagram reality. I'm going to show you the real world and what went well, what didn't go well, and what we can improve on. So let's take a look. Our lower molar. So to start with, the roots of this tooth are currently diverging, or I shouldn't say diverging, but they're distally inclined. So what we really want to do is swing the roots of this molar towards the mesial. This is a hard movement. It's not an easy thing to do. What we're going to do to make that happen is we need to go ahead and utilize the right attachments in the right locations. We also need to use the right velocities. And so the way that we're doing that in this case is we're actually having attachments both on the buccal and the lingual of this first molar. Now again, key point for you guys, if this was simply extracting the third molar and backing this tooth up slightly, all this tooth would have to do is it would literally just have to line back up with the crown moving, right? If this guy's gone and we want to back up this crown, all we have to do is just push right here. The roots will stay in the same spot and we'll just upright the tooth like this. My beautiful, beautiful drawing. That's super easy to do because the roots won't move. But because we're actually planning to keep the crown of the teeth in the same location, we are instead trying to swing the roots mesial so that they're going to be lined up more like this, and the crown is going to stay in the same spot. That is a much more complicated plan. So please recognize that and know that if you want to make this easy, you would just extract the third molar, distalize the second molar every day of the week, super straightforward. Doesn't even really matter what attachments you have on that tooth, it is going to work. But because we're trying to swing the root of this tooth, and I don't have the roots showing right now, but look at how the crown changes its orientation slightly. If you can imagine there was roots on this crown underneath it, you would see them moving more mesially. Now, I'm going to point out in our next case, because this is ironically the exact same situation that we're dealing with in the next case too, but how we are changing this plan slightly to make it more consistent. What I want you to think about here is we know that we need to create mesial root movements. I like how I said this was the easy case. It is easy, guys, except for this one concept. The attachment being on the mesial, and you can think of the one on the lingual mesial. This isn't me trying to show the lingual on the other side. We have that attachment lingual. So we have the gingival surface of the two attachments is the surface that is working for us. It's the surface that we're trying to utilize to upright this tooth. And so what I want you to think about is this. Imagine you took your thumb right now and your index finger, and you put your thumb right underneath this attachment right here. That's your thumb. Underneath this attachment, you go ahead and you put your index finger or your pointer. And so your fingers are going underneath there. And then with your other hand, so that's with your right hand, with your left hand, you're pushing down right here. You're pushing down really hard. What we're trying to accomplish here is that as you put your fingers underneath and you're holding on underneath the wings of the airplane, so to speak, and you're pushing down on the occlusal surface of this, what's going to happen is it's going to help lock in the tooth to the aligner and make sure that the movement is actually happening to move these roots to the mesial. Again, this is the most complicated part of this lecture. Don't sweat it too much if you don't understand. The key would just be is if you want to swing roots mesially, put 3 to 4 millimeter horizontal attachments pulled out to their maximum thickness. But essentially, if we want the roots to swing to the mesial, we're pushing down on the occlusal surface here, and we're lifting up on the underside of these two attachments. And that's going to cause a center of rotation. Again, I teach all about this in the Attachments and Biomechanics course, so this will all make so much sense if you take that course. But by creating a center of rotation here, we're able to swing the roots towards the mesial and make that movement occur and help upright that root. But this is a really hard movement. And what ends up happening here is that doesn't fully express, because you'll see then at our refinement that that tooth, let's just jump to this one, is better, but it's still tapered. So sometimes what you need to recognize is the fact that it will take more than one series of aligners to make complicated movements happen, because we're moving roots through bone. And even though we have 40 aligners here, and you say, well, 40 aligners is pretty good, well, osteoclastic and osteoblastic activity has to happen. And so more time is needed for this movement to express. And so after the end of our second series of aligners, so going from 11, we continue doing the exact same movements here. This is where what we accomplished at the end of the series. So we needed to continue on with more movement than what was actually, or more aligners than what was actually shown. Because again, a crucial point here is just because the ClinCheck show that something is happening doesn't mean that it will fully express, right? It takes time for teeth to move through bone. So you have to give them that time. And again, you'll see this. If right now you're saying, Stephen, you said this was going to be easy. This is confusing. It's complicated. I don't like it. Don't worry about it. Hopefully it'll make more sense after the next case, because again, they're almost two perfect cases to go hand in hand, because I'll show this concept and I'll show an area of how I do things much better on the next case to make sure that the roots fully move. So you'll see that on the next one. Okay, but let's go ahead and evaluate where we're currently at on this case, because the last thing that I'll show you in the initial plan that I haven't discussed so far is the attachments on the anteriors. Now, we utilize a lot of lingual attachments in our practice because, let's face it, patients don't want attachments on the buccal of their front teeth. They look ugly, they're uncomfortable, they don't like it. And so our patients get a menu and they choose, do you want them on the buccal or do you want them on the lingual? They get that choice and they make the decision. We don't force them to go either way, they get to choose. Now, the majority of them do choose to do attachments on the lingual, and so that is what we have set up for this patient. Let me show you the lingual surfaces here. So for the most part, it's pretty straightforward. We're just placing more retentive attachments, which are just 3 millimeter horizontal attachments placed on the teeth. These ones are at a slight bevel. And then on the one tooth that has the most rotation, what we've done is we've just oriented the attachment to be opposed to the force that we're going to be placing on the tooth, because what we want to do is we want to push the mesial out and have the distal get pushed in. So this is a mesial out, distal in. So we're going to be pushing then right here on this surface of the attachment to make this rotational movement happen. And then the plastic will push right here to create the other rotational movement. So that's why we place the attachment in that orientation. Okay, so that's the lingual attachments. Everything else here, pretty straightforward. Again, it's not like I hate optimized attachments. I just hate removing attachments and needing to place new ones. So here's where we're at after our first round of aligners. The lower molar has uprighted a little bit. We've intruded our first upper molar nicely. The posterior teeth look fine. We're kind of propped open slightly. We'll address that later. It's no big deal. And then here's the attachments on the upper incisors. We left those on, but the movements have fully happened and everything's nice and straight. So this patient has a very aesthetic option for how we do the anterior attachments. So what are we going to do in this round? Well, we're essentially just doing some expansion in the upper right, a little bit of constriction in the lower right, and working on arch coordination. Nothing too crazy here. It's the same final position as our last ClinCheck, and this is what we accomplish at the end of that series. So this is showing all the attachments removed. Let me actually show you the photos. That'll be a bit nicer to see. So here's the photos at the beginning. Here's the photos at that progress. And then here's the photos after the next round of aligners that we have. So we're still propped open slightly from hitting against the attachments, right? You can see how she's hitting against the attachments. One key point is that patients who choose to do the attachments on the inside of their front teeth, they leave their aligners in when they're eating food. So she does not take out her aligners when she's eating. So this is what it looks like when she smiles. First of all, no anterior attachments at all. So it looks just pretty much like it did before, other than the posteriors. And at the end of treatment, we remove those attachments. And then the other component that we had talked to her about was the wear and the damage that had occurred to her teeth. And so at this point, what she ends up doing is doing some bonding to build back up the worn edges of the teeth. So she gets, oh, let me go to this one because this is the actual day of the bonding. So she goes from here to here, and we previously lined up the gum lines of the teeth to be more in line with each other. So then the bonding can now occur to restore the aesthetics of the teeth and make them look like they should, as well as to ensure that she has proper canine rise and proper disclusion of the teeth. Now, a lot of times doctors are asking me and saying, but Stephen, if you do fillings on the anterior teeth, aren't we just going to break them all off? And the answer to that is yes, if you didn't fix the orthodontic position of the teeth. But because we fixed the orthodontic position of the teeth, it's not the same situation. All of her lowers are hitting evenly, whereas before she was hitting some teeth heavier than others. You can see the space that we've created for another premolar sized implant. And again, it wouldn't have been wrong to create more space and do a full molar. It's just this is the option that we decided on to keep that second, or the wisdom tooth in occlusion. You can see that at this point right here, we were still open slightly in the posterior. Well, here's the thing is like, I am not worried about being slightly open in the posterior. And again, I teach this in the courses, but what we're actually doing with our very last round of aligners, which I call our temporary retainers, even though they're aligners, is we simply settle the bite. So this is my very last round of aligners, which is happening at this point here. We take off all the attachments. Here's the ClinCheck. We just settle the bite. We let the teeth come into a stronger occlusion so that now when we look at our occlusion, we've got good contacts. Right? We let the occlusion settle. And so from here to here, with 6 months of wearing these trays 18 hours a day and letting the posterior occlusion settle, we end up with nice intercuspated occlusion. So that's a strategy that I use on a majority of cases, is that when we go into retainers, we actually don't go right into Viveras or anything else. What we're actually doing is we're actually focusing on having the Invisalign aligners as our temporary or active retainers, which is only something that you know. If you tell the technician, please give me active retainers or temporary retainers, they won't know what you're talking about. There's a whole format for how I show doctors how you can actually get these temporary retainers, because oftentimes the techs will say we can't give them to you because there's not enough movements. So in the courses, I teach you how to go ahead and make sure that you can get those trays to settle the bite, because we almost never trim trays. We never really bond buttons to teeth. We settle posterior open bites using aligners in a very efficient and effective way, because it's a complete waste of our clinical time to spend all this time and energy settling posterior open bites with techniques when we can just let gravity do it for us instead. So again, I hope that makes sense, just from a perspective of how we bring it from this point here to this point here is simply just from using more aligners without attachments just to settle the bite, with 15 aligners over the span of 6 months. Okay, I'm gonna go ahead and take some questions, and then we're gonna take a quick 10-minute break before we go into our next case, because I know it's obviously late on the East Coast. And do we have questions? How do I see them? More questions and answers, lots of them. Okay, can you move the lower right second molar mesially to replace the missing lower right first molar? Oh boy, that is a question. Yes, it is physically possible to move this tooth forward to close the space. But when you have a significant amount of space, it is an extraordinarily challenging thing to do without utilizing TADs and segmental brackets. I was actually just sharing a case with the doctor in Clearly Select in our chat group who was wanting to do just that. And so I walked through that whole process, probably another hour-long lecture for me to explain that to you. It's doable, but you have to use a TAD, or else what's going to happen is, let me go back here. If you try to move forward this molar, you will have the lower premolars distalizing as well, if you're moving in 10 millimeters like this. And so your midline and all your lower teeth are going to shift towards that extraction space as well. So that's why using a temporary anchorage device is needed if you're planning to do that, and you need to expect that this is going to take 2.5 years. Could we have corrected the class 2 on the patient's right-hand side? Yes, we could have done a better job of it for sure. If this patient was utilizing class 2 elastics with sequential distalization, then we could have gone ahead and tried to sequentially distalize these teeth to put them more into a class 1 occlusion. In some cases, I would choose to do that. In others, we don't. Now, we had the choice here between, do we want to finish this lower first molar in class 1 occlusion, or do we want to finish the canine in class 1 occlusion? Because if we're going to be backing these teeth up, then we would be putting this molar into a slight class 3 occlusion if we're keeping the amount of space required for a premolar sized implant. And so that's where I made the decision to say, rather than distalize these teeth and make it so the molars are not biting in ideal occlusion, we'll leave it so that the canines are actually still biting slightly class 2. Now, again, there's some nuance to that, but that was essentially the decision that we had with the patient, was how compliant do we think they're going to be with class 2 elastics and sequential distalization? And that's where we decided, let's leave the molars in the class 1 rather than the canine. Okay, let's see what's next. These attachments for the lowers have no bevels, is that correct? Yes, that is correct, that our lower molars and premolars, these attachments in ClinCheck number 5, they have a slight bevel, just very, very slightly towards the occlusal surface. But for the most part, there's no bevels on these attachments on the lower premolars. In contrast, the upper anterior teeth, if you have the attachments going on the buccal surface, I should say, let's go back to our modifications. If I was placing attachments on our upper anteriors, I almost always place a bevel. For those who don't know what a bevel means, it's essentially when you set up your attachment and then you grab it and you blend in the surface of that attachment either towards the gingiva or towards the incisal or occlusal. So this would be a gingivally beveled attachment. So upper anteriors, when it's buccal attachments, almost always have a bevel. Lower, well, for that matter, any molars or premolars never get a bevel where, in my opinion, where you blend them right into the tooth. I would almost always focus on having no bevel for the most part. Never say never, there is some exceptions. But I wouldn't normally bevel it. Instead, I would actually utilize the side surface of that attachment to lock the tray in by having it pulled out to its maximum thickness. The reason why is that I want for there to be some forgiveness in the anteriors. Again, this concept's hard to show without having some specific slides, but I want for the trays to be able to have a bit of forgiveness with how they fit over top of this attachment in the anterior, where the trays stop fitting more frequently. Whereas in the posteriors, I want the most retentive attachment possible, where we have a nice crisp surface, and this crisp surface here is what's really locking into place. Did we do any IPR to avoid the 6, the first premolar or the first molar, from getting hung up? No, we didn't need any IPR. I would just tell the technicians, do not allow collision tolerance between the teeth. So as long as they create enough space around this, there's no reason that this needs to have IPR. But make sure you ask your technicians, please have 0 collision tolerance. So I would just say this. I say this on every single ClinCheck, if I know how to spell properly, whatever. 0 collision tolerance as the teeth move past each other. This essentially means that there is no friction occurring between the teeth in any way, shape, or form. So 0 collision tolerance as the teeth move past each other. One more question, and then we'll jump into break, and then we'll come back with our last case. So I understand we're just putting attachments on the neighboring teeth to lock the tray in, but are these only occlusal forces that are causing intrusion on the 6? How about putting an attachment on the 6 more occlusally to cause intrusion? You don't need it. You really don't, because it's only the attachments on the occlusal surface of this tooth is so big right? Look at the difference between this that we're working with right now. We have this much surface area to push against. All of this is getting pushed. Imagine I'm putting arrows here going up into the computer screen versus this. Now I did have that attachment, but it doesn't matter. The amount of surface area from this occlusal surface exceeds the surface area that you are going to create by putting an attachment there because there's so much surface to push against already. And so why that's clinically relevant is you could have a case like this where I show this one. I showed this as one of my summit cases last year. Okay, patient literally had a tooth buzzed down out of occlusion from endo. So that is the tooth. It's this right here. And the tooth has now super erupted. It's an occlusion. We need to intrude it to make the gum lines back even. So we need this to go up. So we can absolutely place 2 attachments on the neighboring 2 teeth and intrude this tooth without any attachment on it whatsoever. So you never need an attachment on the tooth that's actually intruding. We'll jump back into it. Again, I know there's a lot of clearly select doctors who are on this call right now, but I know there's a lot of people who aren't as well. The main things I want you to know is just, again, that we don't even talk about that component for the most part right now. Is there's obviously significant education that we want to provide and support, but there is massive financial benefits, both from Invisalign and other companies too, where we're able to utilize the power of our group to gain significant discounts. And that's the reality is pretty much any doctor who's joining our group is going to be paying back any cost involved with the education or being in the group so quickly because you're saving so much money on Invisalign, on dental monitoring, on other products. Like even today, there was another company that we just had a conversation with, and we're able to get discounts that are the same as what Heartland has. Like that's so cool to me. I love it so much. Is just being able to bring this back, and we're not taking like a cut or anything like that from this particular discount that we just leveraged today. Like we do it just because we want to be able to help support our doctors. Now, if you're an associate, that's obviously can be a selling point for any principals that might be involved in the conversation with joining Clearly Select. If you're in a DSO or you're in an organization of some kind where you're getting a discount, it doesn't mean that you can't still be a part of what we're doing on the educational side and on the support side. There's just so much opportunity available. And this is honestly, when I go to sleep at night, I dream of one thing, and that's how do I support general dentists have the tools to do better? Because one of the questions that was still in here was, if we know that we need to have attachments next to the tooth intruding, why doesn't Align create a ClinCheck that does that for us? It's a fantastic question. The reality is that there's a lot of nuances at play with how the optimized attachments work and how they're designed and planned and created. And there's different orders of movement. And it still requires so much involvement from doctors to be able to jump in. And it doesn't take a lot of time. I know these ClinChecks I'm showing you right now have a lot involved with them. But when you get good at it, it doesn't necessarily take a lot of time to plan and create a case that's going to work and work consistently. But here's my answer to you is if every single doctor could go ahead and do Invisalign and it worked every single time, well, then you couldn't go and charge significant dollars and be able to treat all these patients because Smile Direct Club would just do it for us. So the fact that there is work involved to me is not a problem. It's actually a good thing. Now, even if it does get to that point, there's so much more involved than just setting up a ClinCheck when it comes to how we manage our cases. We're essentially a personal trainer, right? That's what we do with our patients is we're supporting them and working with them. And there really is no reason that the role of personal trainer should exist at all because everybody can get a gym membership for $20 a month. So why does the role of personal trainer exist? It's because there's support needed, there's coaching needed to help people achieve success. And that same thing holds true for Invisalign treatment with our patients. So even if everything was perfectly planned that it would work and be consistent, patients still have to wear the trays, and there's still that component of patient and practice management. And that's a huge component of it as well, which again, we run the slickest operation where we're doing 350 to 400 cases a year. And I'm in clinical practice at this point for less than 60 days a year. The average amount that in terms of production making 40% of the gross billings comes to more than $500,000 in those 40 days. So it's more than $10,000 of profit per day that I work because we have the systems, we have the operations, and we've trained the patients properly to make them good patients, or if they're not going to be good patients and they're not committed, I don't want to treat them. So that's where, again, we've learned it all. I've gone through a lot of heartache and headaches along the path and figured out systems that are very effective in our hands. I hope that they're effective in your hands. I just ask the opportunity if this is something that you might have any interest in whatsoever. The reality is this, is if you want it, it's there. You can make $500,000 or $1 million a year easily doing clear aligner therapy. It's the #1 profession in North America is orthodontist. Because where else can you work as little as you do with your staff doing all the heavy lifting for you? You can avoid the back pain, avoid being in procedures all the time. You can leverage up and have better scalability in your practices. After I finish lecturing on a US tour, I'm going to be touring around. I'm 10 days in a row lecturing, and then I go to Italy for just under 4 weeks. We'll still be starting cases while I'm gone because we never start a case when I'm in the practice because it's clinically inefficient for me to be there when we're just bonding attachments. That all happens when I'm gone under the associates. They're the ones who are in the practice if the staff need them for something, which they never do. Again, if you want to do that, if you want to set this up, you give us the opportunity and you're willing to put in the work, because that's the reality, is that orthos go through a 2 to 3 year residency to do what they do. And we think sometimes as general dentists that we can do that in the span of a 1 weekend course or a 1 evening course. It's a dream. That's never going to happen. We can learn 80% of it with 20% the amount of work or less than what orthos have to put in for their residency, but there's still work involved. And so that's where I think it's just really important to still recognize and understand that if you're the right doctor joining Clearly Select, we'll help set you up on that pathway. We'll give you all the resources that you need. And we have so many doctors that have gone from being silver doctors to gold, gold to platinum, platinum to diamonds. Again, it's super cool. It's super gratifying. And so thank you for those who are currently in Clearly Select for allowing me to take you on that journey. And if you're considering it, check it out. I mean, again, make sure you're the right doctor. You have to be committed to this journey if it's what you want to do. But if you're on board with it, my guarantee and promise to you is I'll be there and I'm not going to let you down as long as you're willing to put in the work.